Good day everyone, this is the video presentation for nephrotic syndrome, prepared by Ms. Nicolen Sabando and I, Shamil Eleda. As an overview, here are the subtopics that will be discussed in this video. Description, risk factors or causes, pathophysiology, clinical manifestations and laboratory findings, treatment such as medications and procedures, nursing diagnosis, and nursing management. As an introduction, let us describe nephrotic syndrome. Nephrotic syndrome is a condition of increased glomerular permeability that allows larger molecules to pass through the membrane into the urine and then be excreted. This process causes massive loss of protein into the urine, edema formation, and decreased plasma albumin levels. The key features of nephrotic syndrome. The clinical manifestations or presentations are massive proteinuria or elevated protein, particularly albumin, in the urine. Hypoalbuminemia, which is the low levels of albumin in the blood. Next is edema or swelling due to fluid buildup in bodily tissues. Another one is lipiduria or presence of lipids in the urine. And hyperlipidemia or elevated levels of lipids in the blood. Increased coagulation, and lastly, renal insufficiency or the poor functioning of the kidneys. Nephrotic syndrome can be primary or secondary. Primary being a disease specific to the kidneys. The primary causes are minimal change nephropathy, focal glomerulosclerosis, membranous nephropathy, and hereditary nephropathies. Secondary naman is the renal manifestation of a systemic general illness. It can be caused by diabetes mellitus, lupus erythematosus, viral infections, amyloidosis and paraproteinemias, preeclampsia, and alloantibodies from enzyme replacement therapies. Let us now move to the pathophysiology of nephrotic syndrome. Here in this diagram, the blue boxes are about the pathophysiology, the purple boxes are mechanism, the green are signs, symptoms, or laboratory findings, and the pink is for complications. Nephrotic syndrome is a condition involving damage to the epithelial side of the glomerular capillary wall, resulting in thicker glomerular basement membrane and loss of podocyte foot processes, both of which reduce the size and charge barrier to prevent protein filtration out of the bloodstream, which leads to massive loss of proteins in the urine. There are many causes of nephrotic syndrome. First, the membranous glomerulonephritis. This is where antibodies attack the podocytes, which are specialized epithelial cells that cover the outer surfaces of glomerular capillaries. Kapag itong podocytes ay na-damage, yung glomerular basement membrane ay magtithicken, and then this will destroy the charge barrier to prevent protein filtration. Second, minimal change disease, which also damages the podocytes on the epithelial side of the glomerulus in a process called podocyte effacement, or the flattening of the foot processes of the podocytes. This also destroys the charge barrier to protein filtration. Third is diabetes mellitus. The chronic hyperglycemia can damage glomeruli through complicated mechanisms. Fourth is the focal segmental glomerular sclerosis, or FSGS, which directly injures the glomerular epithelium and endothelium. Fifth is a cluster of kidney disorders, which include membranoproliferative glomerulonephritis, or MPGN, lupus glomerulonephritis, post-infectious glomerulonephritis, and immunoglobulin A nephropathy. Since they are all autoimmune diseases, they all deposit immune complexes into the glomerulus, which also directly injures the glomerular endothelium and epithelium. Finally, the last one is amyloidosis, which is a disease involving the deposition of immunoglobulin light chains. When these light chains deposit into the glomerulus, that damages the glomerulus. Simultaneously, amyloidosis also results in more immunoglobulin light chains being filtered out into the urine. which then can be reabsorbed back into the blood. The overflow of immunoglobulin light chains into the urine will result in proteinuria of greater than 3.5 grams per day. Going back to the main mechanism, glomerular damage makes it more abnormally permeable to proteins within the blood plasma. Proteins are thus excessively filtered out from the blood into the urine. This results in two basic pathophysiological processes. First is the excessive loss of albumin, which is the main plasma protein in the urine. Excessive meaning in the nephrotic syndrome range of greater than 3.5 grams per day of proteinuria. The loss of albumin through the urine means a reduced level of albumin in the bloodstream, which results to a condition known as hypoalbuminemia. Since 50% of serum calcium is albumin-bound, the total serum calcium will be reduced. So remember that serum total calcium levels do not reflect ionized calcium levels or the free calcium levels. It is actually the free calcium levels, that's the biologically active calcium level, that we care about. So because we can't measure the free ionized calcium level, we can only measure the total calcium level in the blood. Less calcium bound to albumin would make a high free calcium level appear artificially normal, so we should add 0.02 millimoles to the total calcium level that we measure for every 10 grams per liter drop in albumin below 40 grams per liter. Hypoalbuminemia also affects the anion gap. The anion gap, remember, is mostly due to the negative charge of plasma albumin. The less plasma albumin will result in a reduced anion gap. Therefore, for each 10 gram per liter drop in the albumin level below 40, we need to add 2.5 to the calculated anion gap to get the correct anion gap value. The loss of albumin through the urine also reduces the oncotic pressure of the blood. This results in the blood having a reduced ability to retain fluids within the blood vessels. Fluid will then leak into the extravascular space, resulting in underfill edema. If this edema is generalized or sa buong katawan, it is called anasarca. But sometimes this edema can only be located to the periorbital areas, which is a classic sign of nephrotic syndrome. The reduced oncotic pressure of the blood also signals the liver to increase albumin synthesis, only to have it filtered out by the kidneys. However, this increased anabolic activity of the liver will increase lipoprotein synthesis as well, resulting in hyperlipidemia, which consists of increased serum LDL, VLDL, and triglycerides. More lipids are thus filtered into the renal tubules and end up in the urine, which result in lipiduria presenting as lipid or fatty casts and Maltese cross sign under polarized light. The second main pathophysiological process that is triggered by nephrotic syndrome is the loss of anticoagulant proteins such as antithrombin, plasminogen, and protein C and S into the urine. Since the counterbalancing anticoagulant proteins are lost, the clotting factors such as clotting factors 1, 7, 8, and 10 now have much more activity in the bloodstream. The blood becomes hypercoagulable, then resulting in an increased prevalence of thromboembolic disease. We should note that nephrotic syndrome does not refer to the damage of endothelium. So since nephrotic syndrome does not involve damage to the endothelium of the glomerulus, there is no inflammatory process that is triggered, and the damaged epithelial pores are still too small for red blood cells to pass through. Therefore, there is no hematuria and no active urine sediments associated with nephrotic syndrome. That is all for the pathogenesis or the pathophysiology and clinical findings of nephrotic syndrome.
So for the clinical manifestations of the nephrotic syndrome, the common symptoms include swelling or edema, particularly around our eyes, sacrum, ankles, feet, hands, and abdomen. So this is the major manifestation of nephrotic syndrome dahil sa damage sa mga small blood vessels sa ating kidney, hindi nagagawa na mag-filter ng waste and excess water from our blood, causing swelling in different areas of our body. The second manifestation is yung foamy urine, which is a result of excess protein in the urine, wherein it is a sign na merong large amount and presence of protein in our urine na tinatawag in the medical term na proteinuria. So usually, lumalagpas siya in 3.5 grams of protein in the urine. Normally, meron lang tayong less than 150 milligram of protein in the urine per day, which is 0.15 grams lang. The next one is high fat and cholesterol levels in our blood, or yung hyperlipidemia. So hyperlipidemia is common in patients with nephrotic syndrome dahil sa increased hepatic lipogenesis, which is a non-specific reaction to falling oncotic pressure secondary to hypoalbuminemia. So the next one is the low level of protein albumin in our blood, which is yung hypoalbuminemia. So kapag meron tayong low level of protein albumin in our blood, yung mga water is umaalis sa blood vessels natin and naiipon sila sa tissues, which causes edema. The next one is yung weight gain due to fluid retention. So if there is too much water in our tissue, yung extra fluids na yun can cause weight gain. The next one is the malaise and loss of appetite. In severe cases of nephrotic syndrome, some complications may occur, such as yung acute kidney injury. So in this, yung kidney natin suddenly stops functioning properly dahil sa lack of blood flow in the kidney. The next one is anemia. So sa anemia, it may occur if hindi enough yung healthy blood cells natin to carry oxygen sa body organs. One is yung coronary artery disease, which is, diba, kapag nag-build up yung plaque in our arteries, kaya nabablock yung supply ng blood in our heart. Last one is the hypertension or the high blood pressure. Kapag yung pressure and force ng blood na nagpo-flow in our blood vessels is mataas in the usual state. So in the laboratory findings, the first one is the urine protein test, which shows proteinuria if there is a greater than 3.5 grams in 24 hours. So meron po tayong tinatawag na first morning urine protein creatinine, which is madali siyang ma-obtain than 24-hour urine studies. It is more reliable to test proteinuria, so the patient may have nephrotic syndrome if the urine has protein creatinine ratio of more than 2 to 3 milligrams. The next one is the urine dipstick that confirms proteinuria. So in proteinuria, it is diagnosed through urinalysis, often with dipstick test. However, it is not very precise po. So kapag mayroong persistent proteinuria, it occurs in people with underlying kidney disease or other medical problems. So the last one is the urine protein creatinine ratio, which indicates greater than 3. So the normal protein creatinine ratio po in children 6 months to 2 years of age is less than 0.5. In children naman is less than 0.25 above 2 years old. And in adults naman is less than 0.2. So when nephrotic syndrome is diagnosed with proteinuria of greater than 3.5 grams in 24 hours, the following laboratory evaluation is needed. So number 1 is blood test, wherein it shows the low levels of the protein albumin and often decreased levels of blood protein overall. So loss of albumin is often associated with an increase in blood cholesterol and blood triglycerides. The creatinine and urea nitrogen levels in your blood also might be measured to assess your overall kidney function. The next one is the kidney biopsy. So the doctor might recommend removing a small sample of kidney tissue for testing. So during the kidney biopsy po, a needle is inserted through our skin and in the kidney. So kidney tissue is collected and sent to a lab for testing. So for the treatment, including the medication and procedure. So first is the medication, wherein number 1 is the blood pressure medications. So for example po nito is yung mga angiotensin converting enzyme inhibitors, which reduces blood pressure and the amount of protein released in the urine. The next one is the water pills or diuretics. So dito po nakakatulong ito to control the swelling by increasing our kidney's fluid output. The next one is the cholesterol-reducing medications, wherein, for example, is the statins that can help lower cholesterol level. However, it is not clear whether cholesterol-lowering medication can improve the outcomes for people with nephrotic syndrome, such as avoiding heart attacks or decreasing the risk of early death. The last one is the blood thinners or yung mga anticoagulant. So, this might be prescribed kapag there is a decreased ability ng blood natin to clot, especially if you have a blood clot. So, in the procedure, it includes dialysis catheter insertion and renal transplantation. So, first thing is the dialysis catheter insertion, wherein kapag long-term na yung nephrotic syndrome, it can initiate irreversible kidney injury na nag-lead to kidney failure, which requires a treatment with dialysis. So, the next one is the renal transplantation. So, it is the ultimate treatment for pediatric patients with end-stage kidney disease, including the nephrotic syndrome, in the first year of life. So, for the nursing diagnosis, number 1 is the excess fluid volume related to fluid accumulation in tissues and third spaces. So, it refers to a state po wherein the body retains more fluid that it can eliminate or regulate properly. So, mayroong excess fluid na present in intravascular or within the blood vessels, interstitial or between the cell spaces. So in this case po, the fluid accumulation in tissues and third spaces refer to the areas in the body wherein yung fluid is naiipon siya and hindi siya easily measurable, such as sa pericardial sac, pleural space, and peritoneal cavity. So, nag-i-indicate ito na mayroong abnormal retention of fluid in the body tissues and spaces beyond the normal compartments na nagli-lead to increase in overall fluid volume. So, yung kidney natin may not be adequately exerting or excreting fluids and waste products, leading to fluid retention. So, the number 2 is the risk for imbalanced nutrition, less than body requirements, related to anorexia. So, nag-i-indicate ito na mayroong risk of the patient in not receiving or ingesting an adequate amount of nutrients na kailangan ng ating body as a physiological needs. So, dahil sa decreased appetite or aversion to food, nag-lead to insufficient caloric intake. So, the next one is the risk for impaired skin integrity related to edema. So, it refers to the potential vulnerability of the patient to develop disruptions or damage to the skin. So, ang skin integrity is essential for protection against infection and maintaining overall health. So, kapag mayroong edema, there is an abnormal accumulation of fluid in the interstitial spaces, leading to swelling. So for the nursing management, number 1 is to assess and document the location and character of the patient's edema. So kapag nakakatulong po ito for early sign of significant fluid retention, which could eventually result in certain conditions. Next one is to note any swelling in the eyes or the ankles and other defendant part. Next one is to measure the blood pressure. In this po, damage to our glomeruli and the resulting buildup of excess body fluid is nagre-result po siya sa pag-increase ng ating blood pressure. Next one is to accurately monitor and document intake and output. So ito po, nakakatulong to para ma-ensure natin na yung patient has a proper intake of fluid, and yung pag-record ng output naman is to determine whether there is an adequate output of urine and normal defecation. Next one is to weight the patient at the same time every day on the same scale in the same clothing. So this will provide a more accurate determination po kung yung patient natin is bumabawas ang timbang. So next one is kapag sa bata po, we need to measure the abdomen daily at the level of the umbilicus. Kasi kapag mayroong build-up of fluid in the abdomen, it may indicate liver failure. Next one is to frequently monitor urine for protein, to monitor plasma albumin concentrations to evaluate overall nutritional status, and to balance the activity with rest periods and encourage to rest when fatigued. So that concludes our presentation, and thank you po for listening.